All right, let's get started. Hey everyone, again for like the fifth time, my name is Derek Robinson. Thank you all for coming. I want to be able to introduce Dr. Rawal, but real quickly before we get started, I just want to give a real quick explanation for all those who are not familiar with Aspen Dental before we start talking about implant dentistry. We are offering a free CE opportunity to all non-Aspen dentists. That includes every dental student out there that has the ability to visit this page to check out our CE catalog at aspendentalce.com/welcome. There's an entire library of previous CEs that you can take advantage of, in addition to upcoming CEs that will be virtual. So it's a great opportunity. Feel free to check it out, especially if you have any questions on that. We can certainly have a discussion at the very end if it's implant related, or you're welcome to contact me regarding it. Again, I work specifically, and Dr. Rawal as well, work for Aspen Dental Management. And we are a dental support organization for all those who are unfamiliar with us. We have approximately 830 offices, and we're upcoming on 43 states being open with all of those offices. We are here to support all of the doctors inside those offices. So we have the ability in order to help you to reach your goals, be able to guide you in the right directions, and be able to assist you regarding anything and everything that you want to do online. So without further ado, I know I'm not here to be the talker, so I'm going to introduce Dr. Sundeep Rawal.
Thank you, Derek. Appreciate it very much. Welcome, everyone. Good evening. Good, I guess, early evening for you guys in California. The tender time of 6 p.m. It's a little after 9 o'clock my time on the East Coast. So very, very honored to be with you all here today, and excited to be able to share a little bit about some of the innovations that we have in dentistry in general, some of the amazing and exciting things that we're doing here at Aspen Dental. It's just an incredible time to be in dentistry today. And, you know, for those of you that are, you know, beginning your journey into this wonderful profession, you guys are coming in at just an unbelievable time. Technology and innovation has changed everything that we do in dentistry today. And how all of you are being taught currently in dental schools is going to be just built upon very rapidly with technology, and it's going to change amazingly fast as you innovate in dentistry when you get out into practice. And I think that there's, you know, it's easy for me to say there is not an environment where you can innovate and flourish any better than here at Aspen Dental. So I'm excited to be here. I'm excited to talk to you about everything going on in the industry today with implant dentistry, and touch on, like I said, a lot of the stuff that we've embraced and brought into our ecosystems. I'm hoping that this can be a very much a dialogue. So I would ask that you guys ask questions, type them into the Q&A, and then I'll answer them as we go, and then we'll set aside some time at the end for some Q&A as well. So I'm great. We already got one question here. One I'd like to cover is, how long do implants typically last? That's a great question. Look, implants, if you look at the science and the literature out there today, implants are by far the most successful treatment modality we have in all of dentistry. Whether you talk about natural tooth, restorations that are full coverage, if you talk about endodontic procedures, any type of operative procedure, you look at the long-term data that we have today, and I'm not talking 5 or 10 year, I'm talking 15, 20, 25, 30-year data. Implant dentistry is the most successful modality that we have by far. That being said, that doesn't mean that, you know, implants can't have complications, albeit they're very, very low, but they are the most successful modality that we have. If you look at 20-year data today, we have data that shows us it's in the mid to high 90 percentile in terms of success. And there isn't really anything else in dentistry we can say that about. You know, we all know that the average crown or bridge restoration, you know, on average lasts somewhere between, you know, 10, 11 years for a full coverage restoration to 15 years. something in that ballpark. And so, it's really exciting because obviously having this kind of statistical confidence to go tell our patients, this really is the best thing for you. And it's something that will last you better than anything else I can offer you. That's really powerful, and it's impactful when you talk to patients about this. Another question is, can you share some resources in terms of the literature? Yeah, there's plenty of literature, and I'll work with Derek to get that, so we can get those kinds of scientific studies out there for you, so you can look and see that the long-term data supports this. Okay. And then basically, my goal here today is that we just have a nice dialogue about all the innovations that we have in dentistry today. And the next question is what's the best way to learn about implants coming out of dental school? Your goal is to learn in the first year or two of practicing. I mean, look, obviously it's impossible to learn everything you need to know about implantology in 4 years of dental school when you're learning everything else there is about dentistry today. I think that's one of the benefits that I'm proud of in our ecosystem here at Aspen is we thrive on providing that kind of education. We have a comprehensive curriculum on dental implantology, starting with the basics of diagnosing to the definitive restorative concepts, all the way to the surgical application of placing dental implants, from the single tooth aspect all the way to the most complex full arch treatment modality. And so, Doc, to answer your question, it's one of those things where you have to embrace dental implantology as a lifelong journey of learning when you graduate dental school. It doesn't end there with that diploma. You got to keep learning, keep improving, keep bettering yourself. And that's what I want to talk to you about today, because now we know that we live in an unbelievable time with implant dentistry. And we have goals when it comes to our implant dentistry and what we're able to offer our patients. And, this is my goal when it comes to implant dentistry. But gone are the days of us looking at things in black and white. When I did my training, and for some of you that may, be faculty or established dentists already that have been, offering dental implant therapy for a long time, you'll remember that there was a time in implant dentistry where we would say to somebody, if you're missing a tooth, if you've got a black space, we can fill it. We can fill it with white, and we can give you back a tooth. But that was the extent of the conversation. We will fill it with white. We're not exactly sure what it will look like, but at the end of the day, it is essentially, the best thing that we can offer you. Now, that being said, those days are gone. Today, we don't look in black and white. We look in color, black, white, and pink. Today, we talk about concepts like, how do we recreate nature or the illusion of nature? How do we achieve that goal of replacing that tooth that's coming out or is lost with a tooth that looks like a tooth, feels like a tooth, and functions like a tooth? And then how do we do that in the most efficient and innovative ways possible, right? And when we look at that and we have that goal, this is what we talk about with implant dentistry, to rehabilitate a patient to nature, or as close to nature as possible, so that when they smile, their whole face lights up. They've got confidence, they're healthy, and they're healthy not just in the white or the hard tissue, but they're healthy in the pink or the soft tissue as well. The real question is, how do we get to that point when a patient presents looking like this? So here's a classic example of an implant patient who showed up in my practice many years ago, who had implants placed out of the state and then had moved and ended up in my chair and said, "Hey, I'm ready to go. My implants are ready. Let's get some teeth going here." And when we looked at this, I wasn't involved with the planning. I had no say in where those implants were placed. And ultimately, when we look at the definitive restorations that we were able to accomplish, we start to notice a couple of things. So when you look at where the head of the implant should be placed with respect to the adjacent CEJs. We have good literature that supports from our periodontal colleagues that we would ideally like, the ideal placement for the head of the implant is about 3 millimeters apical to the proposed zenith of the free gingival margin. In a radiograph, we can't see the zenith of a free gingival margin because it's soft tissue. And so we say that we have a metric that the implant should be placed 3 millimeters to 4 millimeters apical to the adjacent CEJs. And when you look at this radiograph of this patient we're showing, you can see that the head of the implants were placed slightly coronal to this adjacent CEJs radiographically, meaning they are placed a little too shallow. And when you look at the end result, this is the outcome. Now, you know, I actually, a little bit about myself. I actually graduated from the University of Florida, did my undergrad in dentistry there. And I came out to California. I was a Californian for many years, doing my prosthodontics at the University of California, San Francisco. And, you know, when we were restoring our cases, you know, 15 years ago, we would have been happy with this result. But today I look at this and I say, something doesn't look right. Something does not look right. What's going on with this? And when I look at this and I see what's going on with this, I can see that these laterals are too short. These laterals don't look right. They're not the right length. And so when I say, did I recreate nature with a tooth that looks like a tooth, feels like a tooth, and functions like a tooth? The answer is no, because these teeth don't look like the teeth should. They're too short. And so for those of you that are coming out, what I want everyone to realize is this is honestly a failure on day one. This is a failure of therapy. Now, mind you, we have two perfectly integrated implants, right? Two well-made crowns, good porcelain match, all that. Those implants are going to be in this patient's mouth for another 20, 30 years. They're very, very integrated. But this is a failure of therapy because therapy is not titanium. Therapy is diagnosis to delivery of a tooth that looks like a tooth, feels like a tooth, and functions like a tooth. And so when I look at this and I see that we have a failure on day one, I realized that this was a compromise. This was not an optimal outcome. And in the world we live in today in dentistry and implant dentistry, this is 100% iatrogenic, operator error. If I was placing these implants, it would have been my error. Because we have technology today that allows us to overcome those errors, right? You can see when you look in cross-section of the CBCT of how much width we have and where the implant ultimately ended up. Look how much apical bone we had. We could have buried this implant 3 millimeters, 5 millimeters, 10 millimeters deeper if need be to get the right aesthetic outcome, the right clinical length of that lateral. If you look at the other side, you can see that we really don't have the ideal implant placement. Really is placed in error. And this is 100% avoidable today when we look at utilizing digital technology, right? With the advent of CAD/CAM solutions, diagnosing in software, executing on that plan through some sort of guidance, these types of outcomes should not happen anymore because we have the technology to innovate and avoid those outcomes. So when I look at what we talk about today, it's really about getting into the digital world. And where does that start? It starts with data acquisition. Getting into the digital world with data acquisition. So when I look at this and I think about the concept of data acquisition, I think about this notion of what does that mean? Well, what it means is we're going to work in the digital world. with a digital workflow or a digital ecosystem. And we're going to start with diagnosing digitally with CBCT and optical impressions, or IOS, or intraoral scanning. Plan in software, use computers to aid us in the design of guides of definitive restorations, and execute on that plan to be able to offer our patients predictable outcomes. So it starts with that initial data acquisition, and the technological innovations that we use today center around two pieces of equipment. One being the intraoral scanner, allowing us to get optical impressioning, and CBCT technology to be able to effectively image in 3 dimensions. And, we've had both of these technologies for a long time in dentistry, maybe 20 years, but we were not using them to the fullest capabilities possible. So when I think about the innovations that we have here at Aspen today and what we're able to do within our own ecosystem, it's more than just acquiring digital data. It's actually using that data today. And that's where the use of software, of digital workflow ecosystems that allow us to manage all of this and diagnose in conjunction. You can see I've got CBCT information. I've got 2-dimensional panoramic or radiography or periapical radiography. I've got clinical photography. I've got all of my information in one ecosystem, which allows me to manage my data and be able to effectively utilize it in the most efficient ways. We merge that data together in software. And then based off of that merging, we can then diagnose from an image standpoint, from an aesthetic standpoint, using clinical photography and clinical videography, from a radiographic standpoint, with 2D radiography, 3-dimensional radiography with CBCT, intraoral scanning for diagnostic impressioning. We're able to take all of that data and merge it together. So let's look at another lateral case where we're able to utilize these innovations. And this is how we operate today in our Aspen offices, right? We diagnose how we're going to offer a therapy to our patient through the use of digital technology. In this case, we're going to be acquiring data. We're going to be imaging through our technological innovations like CBCT and IOS. And then we're going to start using that data, which is now the way we all should operate. This is the way we should all practice today. We're going to use this data to the very fullest capability that we have in the industry today. We start with a digital wax up, a digital design to allow us a prosthetic blueprint of where we want to go. And based off of that, we're able to motivate the patient. So we do this wax up. So I call it, I'm still a little old school. I still call it a wax up. We do this digital mock up, right? And in the patient's mouth, we get her motivated, get her saying, yes, this is what I want to look like. She actually started crying because she's never had this image of herself before. So it's very emotional. It's very powerful. And when we know that this is a good starting spot for us, now we're going to take that information and go into software so that we can plan the implants, right? We go from that diagnostic ecosystem of data collection into a digital implant planning ecosystem, all within the same workflow. You can see where we've merged CT data, we've merged iOS, we're making really relevant decisions based off of sound fundamental principles. In this case, you can see we have our CBCT data layered with the existing teeth, layered with our prosthetic blueprint. And then based off of that, we can make good decisions where in this case, we're going to follow our 3x3 rule, which is the science that shows us that our implant head should be placed 3 millimeters apical, 3 millimeters palatal to the proposed zenith of a free gingival margin. Now, when you think about that, we're not guesstimating on a radiograph anymore. We know where the proposed zenith of the soft tissue profile should be. We know where to put the implant exactly 3 millimeters by 3 millimeters so that we can guarantee that the outcome we get will be predictable. Not only that, we can use our restorative innovations. In this case, we're going to be using angulated screw channel technology to make sure that we can go from a diagnostic to a definitive phase with good sound principles. We believe in screw retained restorations. We prefer not to use cement with our implant dentistry. And therefore, we're going to be able to do this by not just having to do complicated procedures to put an implant in with multiple soft or hard tissue grafting, but instead we use a restorative innovation like angulated screw channel technology, and we plan on that in software on day one. It isn't troubleshooting 3 months down the road or 6 months down the road post osseointegration. It's let's plan the case on day one the right way for the optimal result, for the optimal outcome, with the highest level of predictability to achieve the most natural looking restoration. Because remember, our goal is a tooth that looks like a tooth, feels like a tooth, and functions like a tooth. Based off of all that digital data, of the design, off the implant positioning, we create a guide. And now I can effectively operate to the plan, placing the implants where they need to go. Okay, and guidance is something that we feel very strongly about at Aspen. We really believe that implants should be placed with the most predictable protocols possible, including the use of CBCT-based software guidance today. And we have that guidance in the form of static resin guided technology and other newer innovations such as dynamic surgery with camera-based navigation and even robotics. For those of you that are just starting on your journey of implant dentistry, this is kind of a spectrum of how implants have been placed historically. Box one is freehanding it based on just where the bone is, with no consideration to what our prosthetic outcome would be. And remember, diagnosis to delivery, that spectrum from diagnosing to delivery is what we call therapy. Therapy is not just the titanium. Just putting in an implant is only part of the puzzle. So when you put an implant in just based on bone, with no regard to where the teeth need to be or the restorative solution is, you end up with suboptimal outcomes. Well, we refined our process 20 years ago to make it more prosthetically driven, where we would then place our implants with some sort of restorative metric or restorative guide in the form of a surgical guide that was all acrylic based, that had the tooth position so that if you're operating, you could see relative where the tooth should be. But it was still freehand surgery. It wasn't ideal. And in the last 20 years, we've gone to guided surgery, which is box 3, where we base the implant plan in software, and then we execute on that plan, creating a guide or a mechanism to put the implant in where we planned it to be. And now we've even moved into some newer dynamic innovations. Why is this important? Because if you look at the literature that's out there today, we know that if we plan an implant in software and place that implant using a guide, some sort of guidance, whether it's static resin guided technology where you're printing a surgical guide out of resin, static resin guided technology where you're printing a guide out of metal like selective laser sintered chrome cobalt, dynamic navigation based on camera technology like navigated assisted surgery, or haptic feedback and dynamic guidance based off of robotics. Any of the modalities that we have in guidance today, we know that if you plan for an implant in software and you put the implant in and then look at the actual placement versus the planned placement, we know that we can get implants placed within a few tenths of a millimeter in any bodily direction, apical coronally, buccal lingually, mesiodistally, right? Within a couple of tenths of a millimeter and within about 2 degrees of angulation, and maybe even more accurate today. That's amazing. That is amazing to be able to actually plan where an implant should go and then place the implant and get that kind of predictable outcome means that we know that if we start with a good diagnosis, we execute on the plan, we'll end up with a good outcome, right? Now, remember, I want everyone to also understand something about technology. Technology is just a tool. It's not going to tell you this is the right spot for an implant. It doesn't replace clinical knowledge. It's just going to allow you to do your job better, faster, more predictably, and have more ideal or optimal outcomes. So this is why here in our ecosystem, when you're part of Aspen, you get all of the knowledge base that you need, and then the technology layered in on top of it, right? You get the best of every world. We take you through a curriculum that allows you to really understand the why of it, and then how to actually go and operate using technology. And this allows us to get unbelievable outcomes, like this patient that we talked about here, where we place those implants and then we go to actually offer her a restorative therapy or the restorative phase of therapy. With all aesthetic cases that we are dealing with, and really today, almost all cases in general, we try to follow the right steps to recreate nature. And in that, we're going to do a provisionalization phase. We're going to site develop or mold, sculpt the tissue to look a way that we want. And then ultimately, once we know that we've got well established parameters from the provisional phase, we copy that through design software to be able to then offer a definitive phase of treatment that will be predictable. This is software we use to, in this case, create an angulated screw channel technology where we can reorient the screw access channel. And these are the results we get. So we take that patient who's never had lateral incisors and always been self-conscious about her smile, right? And we rehabilitate her to the point where now she loves her life. She's got confidence, right? She goes out and she gets the job she wants. She's got a lot of self-esteem. She loves life. And we're able to impact her in a way that was predictable because we used all of these layers of technology through an ecosystem that was very well defined and very predictable, right? And then we see that because it's a predictable outcome based on science, it stays predictable over time. Here's the 5-year follow-up of that patient. And then we layer in our technology again. And so now we're following her over time through the use of CBCT, through the use of intraoral scanning to monitor her, to see if there's changes to her natural dentition or her implant restorations or anything else. So that way we have over time the ability to track her through technology and be able to make sure that we're able to maintain those therapies at the very highest level. And we started to do this and we realized that there is no way else we want to offer our patients care than through the very best protocols and processes that are out there. Here's another case where we did the same type of workflow and restoration. This was a trauma case, obviously, where a 19-year-old kid was playing basketball. He got elbowed in the face and obviously had a traumatic injury to tooth number 8. He ended up in my chair. This is 4 hours after he got elbowed in the face, 4 hours later. Now, we want, in this case, which is probably the most challenging case in implant dentistry you can do. I mean, everyone thinks it's the complex stuff. It's an all-on-4 or zygomatic therapy. No, the most challenging case we can do is replacing one single central, maxillary central, and doing it in a case of trauma. Because everything has to go perfect if our goal is to recreate nature or the illusion of nature. So what we ultimately end up doing here is we extracted the tooth, we grafted the site to preserve what we could with socket preservation. We obviously didn't want to put any implants in immediately, even though we believe in immediate concepts and immediacy in our Aspen offices. We didn't want to do that in this case because we weren't sure the level of trauma that was involved, how much of the dental alveolar complex may have been compromised. We let it heal, and now we come back and use the same technologies. You can see where we're planning the case, and now we're layering in all of that data. from the CBCT to the prosthetic plan with the intraoral scan. And then we follow the same science. We look at our 3x3 rule. We look to place our implant based off of the free gingival margin or the proposed free gingival margin. And we're able to then appropriately diagnose the type of implant, the size, the length, the width, also the type of restoration we're going to put on ultimately. But it's not good enough just to say I can place a 4.3 by 10 millimeter long implant or a 4.3 by a 13 millimeter long implant. That isn't good enough today. Today, we have to say that's the implant I need, and I need a mechanism to ensure when I go to put the implant in, it goes in the right spot. And that's what my guide is for. This guide can be printed on site in our offices, and you can do same-day guided implant surgery. This is the world we live in today. This is the most state-of-the-art, cutting edge of implant dentistry today, to be able to diagnose in a seamless ecosystem, make predictable, make decisions that are going to lead to predictable outcomes, and execute on that plan all through a seamless ecosystem, with the ability to do it same day if you want. That's the world we live in today in our Aspen offices. And this is the results we get. You can see where the implant's integrated, and ultimately we've done a great job of recreating nature, the illusion of a tooth erupting from the gingiva, giving us the ability to tell our patients we can heal them and do it the way that is going to give them the best life possible, right? And what I love about all this technology and where we are with innovation today is that we have the ability to do this not just from a single tooth application, but even in the most complex situations, when we're dealing with the most severe of limitations, terminal dentition patients who are dental cripples. Not only are they dental cripples, they're actually lifelong cripples, or life-impacted cripples, I should say, because if they've got to a point where their teeth need to come out, then somehow, some way, they've impacted their life because of their teeth. Whether it's the foods they like to eat, the restaurants they go to, how they socialize with people, the level of confidence they have, their appearance, their image, their self-esteem, who they date. All of these things get wrapped up in their life and with their teeth. And the reality is, when they're a terminal dentate patient or an edentulous patient, their life has suffered. But we have the ability to change that in their life today. And we have the ability to do that, to recreate a foundation that's going to give them predictable outcomes, utilizing the same technologies or the same technological innovations, right? That's what I love about our offices and our ecosystem, is that we have the ability to live in a world where, from the single tooth to the most complex, we can actually offer routine, predictable outcomes to patients because we've leveraged technology to do so. So when we look at a case like this, where a patient comes in, this sweet lady, she's had some implants placed in the past, she's been holding on to dear life to these teeth. These two front teeth are like 3+ mobility, right? But she's been so afraid that she'll walk around without any teeth, that she's just been babying them for years. I used to fondly call her Mrs. Applesauce, because her chief comment to me was, "I hope to never eat applesauce again. I'm tired of applesauce." So, these kinds of cases, we've got to take out teeth, we've got to put in some implants, you got to give them back teeth. It sounds so complex. But rather than it sounding complex, we demystify and simplify it through the use of technology. Again, taking our fundamental knowledge and applying it through technology. You can see where we use intraoral scanning to image where the existing restorations are, where the existing implants are, right? Where the occlusion is in the opposing arch. And then based on this information, knowing the emergence profile of those implants, because we can then make a fixture level impression in intraoral scanning, we're then able to really get sophisticated with how we plan this case. In this case, we did a digital smile design. We replicate the aesthetics that we want and create a provisional. This provisional actually engages the existing implants. And so we're able to, in one day, take out those terminal teeth. We're able to screw this on and even incorporate additional implants to give her the very best outcome. She's a patient who is deathly afraid of losing her front teeth to the point of eating applesauce for years as these flapped up and bent down. Instead, now we're able to take her out of that fear, give her back her confidence, do it in a way that's unbelievably predictable because we use this technology of intraoral scanning. And we're able to do that and then follow that through in an immediate protocol with immediate load and immediate function in the full arch, concept similar to the protocols that we espouse with the all-on-4 therapy. And then ultimately copy that as we go to the final work. So now we start to use the digital technology for even more complex solution like full arch, where now we're scanning the patient, we're scanning the provisional that the patient's wearing, because when we know that that's a pretty accurate representation of where the teeth need to go. We scan the occlusion so that we understand where the opposing dentition is and how function plays an important role in what we're trying to accomplish. And then we can layer in things like, where's the implant position, right? If we know where the teeth are, we can layer in where the implant position is. And by layering in the implant position, I'm able to, in one visit, capture all of the relevant data. I'm able to, in one visit, take a patient who's wearing fixed provisionals on implants that we were able to give her in one day, and then in another day, copy all that information to the dental technician in the lab so that we can offer her a predictable outcome. And we do this time and time again. Here's a case of a lower patient who had no teeth. We placed implants, we gave her back teeth all in one day. This is what we call a fixed hybrid prosthesis, or technically a fixed acrylic resin on titanium prosthesis is what the design of the restoration will be. This is the provisional restoration. It's all acrylic, screw retained to the 5 implants that we placed in the mandibular arch. But we're able to follow this very prescribed protocol through technology, where we can scan where the existing dentition is. We can scan the opposing dentition. We can scan the occlusion, the bite registration, right? And so that now we have all of that relevant data in our digital ecosystem. And then based on all of that relevant data in the digital ecosystem, we're then able to start looking at how do we design the definitive restoration. But technology is unbelievable today. It's so accurate that because we can manufacture things in more predictable ways today, we don't need complex appointments and lots of time and many, many visits to try and accomplish this goal. We capture the data and we're able to then go to manufacturing. In this case, an acrylic resin on titanium hybrid. And what's really cool about this is actually a milled acrylic resin on a printed titanium framework. So we're doing additive manufacturing to create the titanium framework through selective laser sintering of the titanium. So it's a printed titanium framework. We're milling acrylic. We're no longer processing like a denture. We're milling acrylic. And we're able to create unbelievable restorations with the highest amount of aesthetic quality, knowing that we've made sure that we're going to have the best of functional capability, and simplified the process. When I was graduating dental school and going into residency for prosthodontics, full arch implant dentistry was the most cumbersome stuff we could do. 20 appointments to do the definitive phase of treatment. Lots of headache. Things didn't fit. Go back and redo it. Remake this, etc. Today, we don't have any of that. Today, we have this unbelievable opportunity to help heal these patients in ways that are efficient and easy. And because they're efficient and easy, we can make them more affordable. And our patients say yes, because they get tremendous value out of something that's very affordable, right? And the last case I want to show tonight is tying the whole package together, a total clinical outcome between diagnosing and digitally designing and manufacturing and executing on that plan. So here's a patient who comes in where we're going to do a full mouth rehabilitation. She wasn't happy with her smile. We're going to start with the maxillary arch and address her aesthetic concerns as well as some of her functional concerns. You can see she's got teeth that are pretty worn down. Aesthetically, she's compromised. A missing tooth on one side. She's had some implant restorations, but all of her dentistry has been done very unpredictably over the years. Well, today we changed that entire paradigm for her. We digitally acquire our data with digital photography, digital videography, CBCT scanning for three-dimensional imaging, intraoral scanning for surface scans of the existing teeth and tissues. We go into smile design software, where now we're able to decide ahead of time what the teeth should look like. What's the appropriate length? What's the appropriate width? How much should she show at rest and at display? We are able to layer all of that information in to our digital workflow. And then, of course, get the patient approval through some sort of mock-up, which we did for her, to say, man, this is what you can look like. This is a vision of health we can offer you. And patients say yes to that. From there, we go into our prosthodontic procedures. We're going to prep the teeth. We're going to make final impressions. But as we do that and provisionalize, we're going to do that through technology again. So you can see where we're scanning, we're digitizing where the provisional restoration is that she's functioning on during the provisionalization phase. We know exactly, we've been testing the vertical dimension of occlusion, her centric relation, her aesthetics, her phonetics. We're doing all of that. Now we're capturing all that data. We're layering all that data in by then using intraoral scanning. And so now you can see where we're able to then take the overlay of the provisionals, and in that same scan, the same file, we bring in the preparations and our scan bodies for the implant position. Because now our patient is going to be able to be restored with all relevant information in the digital world. We can take high resolution imaging so that our dental technicians can know exactly where the crown margins are. We have really accurate representation of where the position of the implants are. We do all of this information, and now we transfer to the lab, and the lab can take the case to finish because they've got everything they need. They've got the aesthetics, they've got the occlusion, they know where the implant positions are. And my next clinical visit after final impression, which today I don't call final impression anymore, I call it definitive data acquisition, right? After that definitive data acquisition appointment, we can then take this with that same angulated screw channel technology, innovate to create optimal outcomes to give our patients very predictable restorations, right? Complete digital workflow. And you see this time and time again from the single partially edentulous patient, single tooth, partially edentulous patient, where we're maybe restoring one implant or 3 implants with a bunch of crowns, to even further to our most complex cases, like here, where we're using software in the most debilitated patient, the severely atrophic maxillary patient who's been told for years that the denture is the best she's going to get, even though the denture doesn't fit, even though she can't wear it, she can't tolerate it, it gags her, it's loose, there's no bone support. But now we do things like zygomatic therapy. We're replacing zygomatic implants. And in our ecosystem, we work hand in hand with the oral surgeons that we have to place these implants so that our restorative doctors can then continue on in the treatment plan. And so you see, we're planning in software where these zygoma implants should go. And this is going to obviously be a big part of what we can do to help patients, right, that don't have any other options. So we'll plan the zygomas, and then we're going to actually operate based off that plan. We use guidance. You can see where the teeth are extracted. We're using a surgical guide to place the implants. We use guidance to help us with the osteotomy position of the zygomatic implants, because that's the most important part, is getting the head of that implant in a prosthetically favorable position. We do that, and then we ultimately use something like this. In this case, it could be a 50 millimeter long zygomatic implant. We place these implants into good bone up in the zygomatic process of the maxilla, and we're able to then get good anchorage with good initial primary stability, which means we can load and give that patient back teeth in one day. And so the patient goes home that day with teeth. We wait for our osseointegration to be fully completed and the body to heal. And then we can go and follow the protocols to take this from provisional phase to definitive phase of treatment. And again, very simple protocols using technology, very efficient protocols. I can take a patient from hi, very nice to meet you, unfortunately your teeth need to come out, to this is the end result. You've got a fixed solution. You're going to be able to live your life with confidence, be the person you want, never have to worry a day in your life, never have to take your teeth in and out, maybe never have to wear a denture. We're able to do all of that complex treatment, what would have been 2 years of treatment and 40 or 50 clinical visits, I don't know, 15 years ago. Today, we can do this, most of this, in as little as 1 day. And we can do the whole procedure in maybe 8 to 10 clinical visits. That's the power of the technology that we embrace. That's the power of the technology that we've been utilizing in our Aspen offices, right? And that's the power of the world of digital dentistry, especially with implantology, that we want to be able to offer patients so that they get the very best experience with the very best protocols, with the most predictable outcomes today. That's where we are in our Aspen ecosystem. I want to thank you all very much. I've left some time at the end here, completely open to answering questions on anything we talked about tonight or anything else you want to talk about in the implant world, in the Aspen ecosystem. Whatever questions you may have, I'm very happy to be able to help you. Thank you.
Well, appreciate it. Everybody give Dr. Rawal a virtual round of applause, even though you can't see him. We got Richard Lee raising his hand. I'm assuming that's an applause. So we received a couple questions prior to the session. In addition, there are some questions that are listed here. Let's just get started. I know today you showed us a handful of unique cases. This is kind of two questions combined. How long I know you mentioned it briefly, how long do some of these implant procedures take from a simple one to a complex one? So, I mean, look, I think the real question is can we embrace immediacy in our implantology today? Immediate load or immediacy, immediate load protocols, immediate placement protocols. Those concepts have been in dentistry now for quite some time. The first immediate load protocols were probably 20 years ago now. So in my mind today, and what we teach in our Aspen ecosystem is, if it makes sense, if the patient's the right candidate, if the site is the right site, if the implant goes in the way it's supposed to go, we embrace immediate protocols. So in immediacy in general. So if we're able to take a tooth out, place an implant that day, immediately provisionalize it, come back, do a definitive therapy in 3 to 4 months, you know, the single tooth implants start to finish may take 5-6 months to be done, all in, everything. Maybe less, maybe 4 months, right? But, you know, it'll take a little bit of time to get that done. If we go to the full arch, we could do these cases, you know, 90% of it in 1 day. And then we could wait 4 months where we could take out the teeth, place the implants, give them back teeth all in 1 day, wait the 4 months, 5 months, and then you can convert them to a definitive phase of treatment, again, under 6 months. Where implantology takes a while is when we have to stage things, where we have to take out a tooth and wait, maybe socket preservation, or do a maxillary sinus lift and wait, grafting procedures. That's where we can get into the year and a half of treatment. So it's not to say that we don't graft. We graft all the time. It's just we pick the cases that are appropriate for immediate load protocols and immediate placement protocols.
and we try to give our patients the best experience, which includes shorter time to teeth. If we can't, for whatever reason, because the patient doesn't have the anatomy or the quality of the bone isn't acceptable, then we stage it and it can take a little bit longer.
Excellent. And to piggyback on that, we received a question. How many number of visits does it typically consist of for one of the examples of your cases?
I mean, look, at the very least, you could say the minimum, you could be, hi, nice to meet you. Your tooth is fractured. It needs to come out. We can put an implant in. We can do that today. One visit, implant goes in. Maybe a post-op check. And then 3 months later, final impression. 2 weeks later, delivery. So, maybe 3, 4 visits at a minimum. Complex cases, 10 visits or less. We have really streamlined how we offer therapy to our patients, right? It's important to us because we want our patients to have the best experience. And just like I said a minute ago, part of that best experience is to not make them come back multiple times unnecessarily when we can gain efficiencies through the use of technology today.
All right, next question. I'm just going to read it verbatim. It's got some substance to it. What is the overall timeline for a patient who comes in with a non-restorable tooth to receive the final implant restoration? I think we kind of mentioned that. And then we generally say 12 to 18 months, never actually happens in 12 at school. I know there's a lot of variables, but what do you generally tell most patients in terms of timing?
So that's a good question. Listen, obviously things take a lot longer in the dental school setting than they do in the real world. As I just mentioned, we believe if it's the right patient, the right candidate, right, the right case, we believe a lot in immediacy. And so, it could be, 3, 4 months start to finish, right? Depends on the patient, the parameters, if you have to do any augmentation or not, but 3 to 4 months. I mean, that's about the shortest time we have. And that's really waiting, 10 weeks or 12 weeks for that bone and implant to osseointegrate. So we've streamlined the process to the shortest possible at this point.
Great. What options have you provided for patients without optimal bone? Previously long-term denture wears.
So there's 2 options there. One is the conventional graft or augmentation procedures, which will allow the patient to have implants placed later on, but that generally requires 6 months of healing at least, not to mention multiple surgical interventions to make that a goal. I believe in immediacy. I've been doing immediate load protocols in the full arch. To your question about patients wearing dentures, we've been doing full arch implantology in our practices now for, well over a decade. And so when you think about that, we have the ability to take a patient wearing a denture and in as little as a day, eliminate that. They can go into, if everything goes well at the time of surgery, get good initial primary stability on the implants, use zygomas if needed, you can put them into a fixed prosthesis that day. And then you wait for about 4 months for everything to integrate, and then you go and do the final work. So, we've streamlined a lot of those protocols, and we do that in less than 8 to 10 visits now today. So both because of efficiencies in placing implants with, newer innovations and better concepts and understanding of how we can immediately load implants in the full arch, and by incorporating technology like digital intraoral scanning and CBCT planning and CAD/CAM solutions, we're able to offer them definitive phase of treatment in as little as 2 appointments, maybe 3 appointments. When I was a resident, that would have been a minimum of 15 or 18 appointments. And so we streamlined all of that down and condensed it to give our patients the very best experience possible.
Excellent. So we received 2 questions on this, and I'm just going to combine them together. First of all, this question, we'd like to say this on behalf. Thanks so much for your time, Dr. Sundeep. The question is, how long would it typically take for a new grad to get up to speed with the implant ecosystem provided by Aspen Dental?
That's a great question. And we have spent a lot of time creating a really unbelievable curriculum. Our typical goal is that the day you join Aspen, your implant learning or your implant journey starts through a variety of online, at-home self-paced learning that we require you to do to progress through communication on a daily basis in our implant communities, which are groups of doctors in your geographic area. As you progress through your first 3 months and you start to meet your metrics in terms of getting better at basic dental procedures, we bring you in for our comprehensive restorative didactic course at the 3-month mark in your career. You go through that course, you go back, you start implementing. You have to meet metrics of really making sure you're becoming proficient at the restoration, diagnosing and treatment planning, and the restoration of dental implants. And then we, once you get really comfortable with that and you meet some metrics, you're eligible to take a surgical course. And we have some people who come in with various skill levels that may qualify for the surgical course relatively quick. Others, it may take them 12 months. My goal is that by 12 months into your journey here, you have the opportunity, to take a surgical implant course. Again, I would never say you'd be ready just, blanketly every doctor's ready on day one. That's not our intent. Our intent is for you to learn to be really good implantologists and to offer your patients the very best you can with dental implant therapy. So that means you got to get good at diagnosing first and treatment planning. Then you got to get good at restoring. And then once you're good at restoring, you get good at placing. But my goal is that every doctor that comes in should be able to accomplish that within the first 12 months. And then as you continue down your lifelong journey with us, you'll have opportunities to learn about full arch implant therapies, learn how to actually treatment plan, restore, and place implants for things like an all-on-4. Even more complex procedures like sinus lift and bone augmentation procedures, complex soft tissue aesthetics, really anything that's innovative in the implant world. We want to be able to be part of the journey for you to learn it if you so choose.
Great. So just to let everybody know, it is 7:01. For Dr. Rawal, it is 10:01. It's getting a little late up there. So we want to be very respectful of your time. We do have a handful more questions. We'll keep it limited to about an additional 10 or 15 more minutes.
Sure.
If it allows. A question we received yesterday was how many Aspen Dental offices are currently doing these implants and how many are planned out?
Great question. Currently, we have nearly all of our offices today have the restoration of dental implants. Our goal is that any office in our entire network will have the ability to offer patients implant therapy because guess what? It is the very best thing for them. We want to offer our patients the very best. So every one of our offices, you can diagnose, treatment plan, and restore implants. As far as placing them goes, we're working towards our goal of having every doctor in the organization place dental implants. Nothing would make me happier, but that's obviously a big lift with the number of offices that we have. I would say currently about a little more than half of our offices are placing implants currently today. And so, I think we will get to a point in the not too distant future, maybe 12 months, maybe 18 months, where every office has the ability to place and restore implants. Okay.
We received a question regarding the complex cases. So what circumstances usually lead to an implant case being referred to a specialist? And how often does that occur when it's out of the scope of a GP?
Sure. So, I mean, look, it's not a question of incidence of how often or what circumstance leads to it. It really boils down to is what is your comfort level? What is your skill and experience? What do you feel comfortable, confident, and capable in terms of offering a patient? Our goal is twofold. One, we want to work hand in hand with our doctors to say, okay, if you're not comfortable, you're not confident, we have a mechanism for you to be able to refer that patient to the right people to get the job done within our own ecosystem. We've got hundreds of oral surgeons on staff today that can help with any type of surgical case that may be a little bit more complex. We have resources like myself and other implant mentors that are able to guide you through the restorative process and the diagnostics and the treatment planning. We want to be part of your journey hand in hand, so that if you do come to a point where you're like, I don't feel comfortable, that resource, that patient stays within the Aspen family as we're able to provide them and offer them care. But I said it was a two-part answer. And the second facet of that is, we also want to make sure that if the only thing that is, the key factor in referring a case out is your comfort, your skill, your confidence, we want to give you all the tools to enhance those. We want to give you the tools to be able to learn, grow, and develop so that you become more confident, you become more capable, and you're able to offer more to those patients, and then you won't feel the need to refer. So it's not a question of, is there a percentage, or, do we have a cutoff? Is there a metric we use? No, we don't tell our doctors how to practice dentistry. We tell our doctors how to do it in the best possible ways, and try to be a team member for them and a champion for them to be able to offer their patients that best possible treatment outcomes, and learn and grow together along that journey.
Excellent. This question, I think, really speaks on behalf of a lot of the students, especially D3 and younger. Do you have any tips for dental students that have limited knowledge in the implant world? And I guess to add on to that, what advice do you have for them kind of navigating through that?
Sure. I think I would tell you, be a sponge, right? Be a sponge. Go out and learn, attend as many of these free CEs that we're offering. It's a gem to be able, it's an honor for me to be able to do this, but it's a gem for everybody to have this kind of opportunity. I'll be honest, 15 years ago, if I wanted to listen to a lecture about the innovative technologies and protocols and processes and implants, I'd have had to fly somewhere, pay a bunch of money, right? Take time out of school or work or whatever to be able to just listen to it. And you guys have a wonderful opportunity, especially with resources like our free CE, to be able to get this at no charge. I caveat that by saying you can't just follow Instagram and YouTube and think you're going to learn everything you need to learn. Because a lot of times on Instagram and YouTube, they show you the before, they show you the after, and the why of it gets lost, and the perception is that you just hit a button, technology takes care of it for you. That's not what dentistry is about. We're healthcare providers. We have to understand the why of it. We have to be able, the most important thing you'll ever do in dentistry is diagnose and treatment plan right. The rest kind of falls into place. And so my suggestion for you that are younger, those that are near graduation, those that are recently graduated, is be a sponge, go out there, take out the opportunity, stay at 6 o'clock at night and listen to a free CE. If you're on the East Coast, maybe 9 o'clock at night.
Go to sleep.
But definitely, take the time to learn, go to resources that are trusted. Look, we offer a ton of free CE for no other reason than we just want to put good education out there so that everyone can be better, and all of our patients are going to benefit. That's why this is not free CE just for students. This is free CE for anyone. And we want to make it so that the very best knowledge that's out there today gets shared and disseminated. And so, in that same vein, those are the kind of resources I would look to. There's a bunch of courses you can take to further your knowledge and your understanding of implant dentistry while you're in school, when you're out of school. Again, I can't stress enough, that's one of the things I love most about Aspen is we really have world-class education, training and development, learning journeys to help people become whatever they want in dentistry. Obviously, I'm partial to dental implants, obviously, but at the end of the day, we have it for everything from orthodontics and innovations with clear aligners to you know, aesthetics and operative and traditional prosthodontics and obviously implantology and endodontic. I mean, we really strive to give a lot of opportunities to people. And I think that's a really, you know, good place that you can turn to as a resource, you know, as you want to, you know, gain your experience and your knowledge base.
And to echo on top of that, Dr. Rawal, again, for those that weren't able to hear it right in the very beginning, Aspen Dental is actually offering a free CE opportunity for all non-Aspen dentists at aspendentalce.com/welcome, where you have access to the entire catalog of CE that essentially all the Aspen Dental dentists have. And it's an amazing opportunity that it's going to be offered during the pandemic. My understanding is it will be offered all the way up until March 2021. In addition to that, if and when you decide to come on, these are such valuable resources on top of Dr. Rawal that you're going to have an opportunity to continue that education. I think this is a great opportunity to say, first of all, thank you so much for everything that you've done. Again, we want to be very respectful of your time. If anybody has any additional questions, as you can see in the last slide, my contact information is there. I'll work directly with Dr. Rawal regarding any unique complex questions on implantology. In the meantime, if you have any questions, feel free to send me an email, or you can send me a text or give me a phone call at the number there. I want to thank everybody once again for coming, and if you have any questions, we will be keeping in touch with you. Thanks again, everyone. Appreciate it.
Thank you guys very much. I hope you enjoy the rest of your evening. Take care.